This is an educational video about syndrome of inappropriate antidiuretic hormone secretion, SIADH. The ADH is also known as arginine vasopressin. It's formed in your hypothalamus and it's stored in your posterior pituitary. Its function is for osmoregulation. The book states that SIADH occurs when the body secretes an excessive amount of ADH due to plasma osmolality. But this means that the failure in the negative feedback mechanism that regulates the release and the inhibition of ADH causes the abnormality of the ADH levels. This results in impaired water excretion, leading to hyponatremia with hypervolemia or even euvolemia. Now, what causes SIADH? Most commonly occurs, it's like a secondary to a disease process that's already in the body, or it could be hereditary passed down. The common conditions that are most likely causing SIADH are like CNS disturbance, like a trauma to the head, a stroke, a hemorrhage, cancer, most commonly small cell lung cancer. Drugs, the most common ones are carbazepine, oxcarbazepine, and chloropropamidine, cyclophosphamidine, and an SSRI. Also, surgery can cause it. Lung disease, it's not really a known mechanism. Hormone deficiency or hormone administration, and having HIV. These incidents with SIADH can increase with age. It's most common in hospitalized people, hospital post-op patients, because they're administered a lot of hypertonic fluids and their body's going through stress. Clinical manifestations of SIADH varies just dependent on the low level of sodium that's in the body, that's and between the cerebral edema. The clinical manifestations are due to hyponatremia and decreased extracellular fluid osmolality. The water will move into the cells, and this will make the cerebral edema, the swelling in the brain. Signs and symptoms, like I said, are dependent on the degree of how low the sodium is and the cerebral edema. The hallmark textbook case of clinical manifestations of SIADH is hyponatremia, hypoosmolality in the presence of concentrated urine. Early signs and symptoms are nausea, malaise, vomiting, severe about below 125. Normal sodium is 125 to 135. So anything below 125, you get headaches, lethargic, and it will eventually lead to a seizure. And then below 115, you can go into a coma and respiratory arrest. On the physical exam, we would be assessing you for the volume that's inside you. Your skin, turgor, and blood pressure would probably be within normal range. Moist mucous membranes, no evidence of JVD or edema typically to indicate euvolemia, but a detailed neuro exam and chest exam are very important. So to really be able to diagnose this, there's not one single test that's certified to be able to diagnose this. There is the Schwartz and Barter clinical criteria that we've been using for 1967 to indicate SIADH. That's with the sodium less than 135, serum osmolality less than 275, urine sodium greater than 40, urine osmolality greater than 100, the absence of the volume depletion, normal skin turgor, blood pressure's fine, and the absence of other causes of hyponatremia, like something wrong with your adrenal glands, hypothyroidism, cardiac failure, such of that sort, and correction needed of hyponatremia by fluid resuscitation. Other tests that we use are renal function tests like the BUN and creatinine, random blood sugar, thyroid profile, just to see if that is thyroid is one of the reasons for the hyponatremia, a cortisol level, potassium, bicarbonate chloride to check for any acidosis in the body, a fasting lipid profile, and liver enzymes. So the treatment plan is kind of like how we assess the severity of it, just based on how low the sodium is and the cerebral edema and how severe the symptoms are. So the SIADH treatment involves correction and maintenance of corrected sodium levels and correction of underlying abnormalities, such as hypothyroidism, thyroidism, pulmonary, or something with your neurological exam. To be able to correct a sodium level, it should be known by healthcare workers that the urine osmolality in such patients is usually twice the amount that it should be. So the fluid needs to be corrected to the sodium levels and must have the osmolality that is more than urine osmolality. Our main goal for treatment is treat the underlying cause, eliminate excess water, and increase serum osmolality to more than 130 MEQs per liter. So obviously there's a lot of complications that can arise with SIADH just based on the severity of the symptoms. Potential complications are headaches, memory problems, depression, tremors, and muscle cramps. For more severe, where the sodium level is very low, respiratory failure, seizures, hallucinations, coma, and death.